And we are good. So welcome everyone to the AMSSM Fellows Online Education Lecture Series. For tonight's installment, we will be talking about exertional heat illness. We'll be hearing from Dr. Seth Smith at University of Florida. I am Dr. Nate Nye. I'm active duty Air Force out here in the DC area, one of the fellowship faculty here. And always does this to me where I cannot advance my slide. There it goes. Okay, so as I mentioned before, this is the National Fellows Online Lecture Series. It's hosted or is sponsored by the Education Committee, as well as the Fellowship Committee, which work together. This is operated by the Fellows Online Education Subcommittee. So again, we'll be hearing on exertional heat illness tonight. Before we dive into that topic, just a couple of ground rules. Well, first, we'll talk about next week's lecture. It's going to be on C-spine injuries with Dr. AJ Monso. That'll be on August 17th, usual time, 8:30 p.m. Next Wednesday. So we encourage you to dial in. Like I was saying, ground rules. This is an adjunct to your individual program's educational, curriculum. And this is meant to provide fellows across the country with access to some of our nation's top experts on a variety of subjects and to assist you in CAQ preparation. So please keep your device muted during the lecture. I encourage you to submit questions through the chat function. And I, as the moderator at the end of the lecture, will be presenting those questions to our speaker, and we'll have that discussion at the end of the lecture. So there will also be an evaluation, which we will ask you to complete upon finishing the lecture. And we do value your input, so please share your thoughts. All right, without further ado, introducing Dr. Seth Smith. Seth is a friend of mine and a colleague. We've presented together on heat illness at past conferences, and just a gentleman and been a pleasure to work with. Seth is a clinical associate professor at University of Florida in the Department of Orthopedics and Sports Medicine. He also has a unique background as a PharmD, so he completed that training and then went on to receive his MD actually at Florida State University. So he's joined the enemy school now at University of Florida. I know he's passionate about heat illness. He's done a lot of work at the state and national level on this topic, working hard to keep high school athletes and college athletes safe. And he is also a member of the KSI, Corey Stringer Institute Medical and Science Advisory Board, and speaks with authority on this topic. So without further ado, I will yield the floor to Seth and take it away. So you'll just go ahead and share your screen like you did before. Here we go.
All right. Thank you, Nate. I want to thank Nate and the AMSSM committee for giving me the opportunity to speak tonight. As Nate said, I'll be speaking on exertional heat illness. Nate and I have had the opportunity. We met through Dr. Fran O'Connor and Dr. Doug Casa many years ago. So wonderful mentors, I think, for both of us. And it's really been fun kind of learning about this and presenting on this. So yet again, I just want to say thank you to Nate and to the AMSSM committee for giving me the opportunity to speak tonight. When we put this together a week or so ago, we had just given this presentation to our fellows, so it was pretty natural. Certainly for those of us here in the Southeast and in the state of Florida particularly, we start to see this as soon as our fellows start, from their first month in fellowship. So we want our fellows to be ready for this because they're going to see it as they're out covering schools for sure. So let's go ahead and get started. I started presenting on exertional heat illness probably somewhere between 10 to 15 years ago. I think it was a natural, it was natural for me as an interest of mine just because of where we live. It's hot, it's very humid. So I started collecting headlines. And unfortunately, when I first started, I just collected headlines for the first couple of years. And those were the headlines that you see on the top of the slide. Unfortunately, I collected 3 in the last year that have happened since I gave this presentation in 2021 to our fellows. So we still continue to see athletes. We still continue to see our military personnel and our firefighters succumb to exertional heat stroke. My hope is that after the next hour that we will all be experts on this. We will educate those around us on this. There's great things we can do to mitigate the risk of exertional heat stroke. And when exertional heat stroke does occur, there are things that we can do to make a significantly meaningful outcome. And I want all of us to be ready for that. So what are our goals and objectives? So number one, we'll describe the differences in classic heat stroke versus exertional heat stroke. And then after that, we're really going to spend most of our time on exertional heat stroke, but I think it's important to know the difference between the two. Two is we're going to briefly discuss the epidemiology of exertional heat illness and exertional heat stroke. We're going to spend a slide or two on the 4 main types of exertional heat illness, really with our emphasis on exertional heat stroke. We'll once again, as I said earlier, we'll discuss the diagnostic criteria for exertional heat stroke, because that's where we're going to want to spend most of our time. We're going to discuss the diagnostic criteria for exertional heat stroke. We'll also describe the prevention strategies to help mitigate the risk of exertional heat illness. We'll discuss appropriate management of exertional heat stroke. And then lastly, discuss the return to play after exertional heat stroke. Okay, so for goals and objectives, number one, we're going to describe the differences in classic heat stroke versus exertional heat stroke. Exertional heat stroke typically occurs in our young athletes, our military personnel, our firefighters, and this typically occurs during strenuous physical activity when they have difficulty dissipating heat. In our population, we typically see these in our hot and humid environments, and in our athletes, this is almost universally seen in August, September, and October. These can be seen in cooler climates, certainly when we are in areas that are not accustomed to the heat during a heat wave. I think it's important to differentiate that these patients may be profusely sweating. So years ago, we tried to differentiate exertional heat stroke versus classic heat stroke by how much someone was or was not sweating. And I really would not let this enter our diagnostic criteria. In regards to classic heat stroke, I think it's important to note that we typically see these in our elderly population or those who are very young. So these are our elderly population that succumb to heat stroke, whether they live in an apartment complex or condominium or a house that doesn't have appropriate air conditioning. We see this in our very young population. These are our kids that we see, particularly here in the Southeast, who may be left in an automobile for too long and succumb to heat stroke in that manner. And our elderly population, they typically are those with chronic medical conditions or certain medications that they may be on that have a profound effect on their thermoregulation. And we usually see these during environmental heat wave, which we've all seen in the last couple of weeks here in the United States. This table was taken from a New England Journal of Medicine article in 2019. This is just another table that you can use that's similar to the previous slide. So goal number 2, let's briefly discuss the epidemiology of exertional heat illness and exertional heat stroke. So if we're looking specifically at exertional heat illness in high school athletes in the United States, it's reported that there's approximately 9,000 exertional heat illnesses treated annually. My gut tells me that this is probably a little bit under reported. My thoughts are there's probably more than this, but this is what we have in the data currently. If we look specifically at high school sports, American football has the highest overall rate of exertional heat illness. We also know that girls field hockey has very similar exertional heat illness rates if we look at practice. Now, if we're looking at competition as opposed to practice, girls cross country actually has the highest rate of exertional heat illness. I think it should come as no surprise for those of us who live in the southeastern or southern part of the United States that exertional heat illness rates are certainly higher here than they are in other parts of the country. If we look specifically at American football as it relates to deaths secondary to exertional heat stroke, since 1996, we've had 68 preventable deaths secondary to exertional heat stroke. These particularly are going to affect our high school, our middle school, and our youth athletes. We've had 50 in the high school population, 13 in the college population, 2 in the professional population, and you can see the numbers in the middle school and the organized youth football there. Now, there has been one specific a case that has occurred in the college population that occurred a couple of years ago at the University of Maryland. But really, other than that, these deaths have occurred more in our high school population in the last few years than in any other classification. If we're looking specifically at 5-year periods, the 2010 to 2014 period had the highest rate. We hope and we think that this may be starting to trend down, which is great. If we're looking geographically, we know that exertional heat illness is widely distributed, but certainly is going to most often occur in August. So for those of you who are out covering, your American football, any outdoor sports at this time of year, as fellowship has just started, I think those that put this fellowship, this online fellowship program together, have done a great job. As risk of exertional heat stroke is going to be this month, it's going to be next month, and for those of us in hotter and more humid environments, certainly in the month of October as well. We know that about 1/3 of these in American football occur in practices that last at least 2 hours. If we're looking specifically at a time period, any practice that lasts over 3 hours really is where the risk of exertional heat stroke or an exertional heat illness occurs. For goals and objectives number 3, we're going to define the 4 main types of exertional heat illness. So we're going to start out with exercise-associated muscle cramps. For those of us who have been athletic or been active or covert athletes, we know that these are painful involuntary muscle contractions that occur during or after exercise. These are going to occur in your quadriceps, your hamstrings, your calf muscles, and your abdominal muscles. Heat syncope is our second type of exertional heat illness, and this is a diagnosis of exclusion. So we should not make this diagnosis initially. This should be after we've ruled out a sudden cardiac arrest, after we've ruled out exertional heat stroke, etc. This is nothing more than just a transient loss of consciousness secondary to pooling of blood in the lower extremities. And this typically occurs after exercise or after prolonged standing. So for those of you who have covered road races and marathons, this is why we have our runners make sure that they continue to walk after they get to the finish line, because the last thing we want them to do is stop running at the finish line and then they lose that contraction in their lower extremity, so they don't get that blood back to the right side of their heart. Heat exhaustion is really where we got to start paying attention. So this is an inability for these athletes to continue an exercise secondary to the heat stress and cardiovascular strain that their body is seeing. These athletes, we really don't want to push them any harder than they are at that current time, and we want to make sure that we back off of that. In regards to exertional heat stroke, we need 2 things to make this diagnosis. So one is exercise-induced hyperthermia, and that's measured by a core body temperature obtained rectally of 104 to 105 degrees Fahrenheit, along with central nervous system dysfunction. So this central nervous system dysfunction can be auditory hallucinations, it can be visual hallucinations, it can be seizures, it can be loss of consciousness. And this is where I really put a plug in for our athletic trainers. And you're going to notice this throughout my presentation tonight is our athletic trainers, those who are at our schools, whether that be at the secondary school level, the Division 1, 2, or 3 college level, the professional level, they really know these kids as well as anyone. So if these kids start acting weird or funny, your radar should really, really go off here and make sure to pay attention to what's going on here. We published this in the American Journal of Sports Medicine in 2015, and just a chart yet again of the 4 main types of exertional heat illness. So just a different way to look at the slide that I presented earlier. Okay, goals and objectives number 4. This is also going to be brief because we're going to spend the majority of our time on the prevention and management. So let's discuss the diagnostic criteria for exertional heat stroke. So as I said earlier, to make the diagnosis of exertional heat stroke, we need central nervous system dysfunction. This can be auditory hallucinations, visual hallucinations. This can be seizures. This can be loss of consciousness, and a core body temperature obtained rectally. And I think that's vitally important to say is temperatures that are obtained axillary or oral, they have been shown time and time again to not be as accurate as core body temperatures obtained rectally. So somewhere around 104 to 105 degrees Fahrenheit, if you operate in that realm, or greater than 40.5 degrees Celsius. We most commonly see this in American football and running races, as we said earlier. This is one of the top 3 causes of atraumatic death in our athletes. And I think the greatest part of this whole presentation, if you hear nothing else, is if we identify this appropriately early, so we recognize it appropriately, and we treat it appropriately, ideally within the first 15 to 30 minutes. This is 100% survivable with limited morbidity. All right, so really we're going to spend most of our time here on objectives 5 and 6. So what are we going to do from a prevention standpoint to help mitigate the risk of exertional heat illness? I don't think it's appropriate to say that prevention strategies are going to prevent all cases of exertional heat illness and exertional heat stroke, but we certainly know that it can mitigate the risk. So the number one on the prevention strategies is I want to reiterate over and over again, for those of you who have the ability for advocacy and for those of you who can make policy changes, I think it's vital that we ensure that all of our athletes that we take care of have access to an athletic trainer. So this is number one on my list of prevention strategies for exertional heat illness. The most recent data suggests that at the secondary school level, about 1/3 of our athletes at the secondary school level have access to a full-time athletic trainer. About 1/3 have access to a part-time athletic trainer, and about 1/3 have no access whatsoever to an athletic trainer. So those of us who advocate for these things and are involved in policy changes, this is something that we can make a difference with. So yet again, I'm going to encourage all of us to continue to make a difference in regards to advocating for athletic trainers for our athletes. Number 2 on the prevention strategy is we want to allow our athletes to adapt to exercise in hot and humid environments. So the term is called acclimatization, and it's nothing more than just progressively increasing the intensity and duration of work in these environments where they're going to participate in their sports. Acclimatization does vary based on the location of the training environment. So it's important to make sure that the environment that our athletes are going to acclimatize in is the environment that they're going to be participating in. So this is taken from the Florida High School Athletic Association, and this is just a sample heat acclimatization guideline for football in our state. So this occurs over a 14-day period. And what you notice is that the first week, we have no 2-a-day practices or no twice daily practices. Total practice time should not exceed 3 hours in the first 5 days. And in the first 2 days, we do helmets only. We don't allow contact and we don't do any sleds. And then we progressively increase their personal protective equipment or their shoulder pads, etc., over the course of that first week. The second week, we do allow twice daily or 2-a-day practices. It's important to note that twice daily or 2-a-day practices should not occur on successive days. So if it happens on day 8, it should not happen on day 9. In addition, if we have 2-a-day practices or twice daily practices, these should be broken up by a 2-hour rest break in a cool environment. This was taken from the Corey Stringer Institute, which Nate and I both work with, Doug Costa and his crew up there. And it just compares the collegiate level to the high school level. These things certainly change over time, but this is currently where we're at right now. And it just compares the acclimatization period for the collegiate level to the high school level. All right, so this is something that we've done a fair amount of research in, and I know Nate is pretty passionate about this, working with our military personnel in regard to creating work to rest ratios based on the wet bulb globe temperature. So first off, I think it's important to know what in the world is a wet bulb globe temperature. Well, it's a thermometer or a temperature gradient that takes into account multiple variables. So the first variable that it takes into account is humidity, which is multiplied times 0.7. It then takes into account the solar load or the radiant heat. This is measured by the black globe temp times 0.2. And then lastly, it adds the ambient air temperature times 0.1. It also includes the wind speed as well to some degree. Okay, so your measurements or your numbers for this are going to be a little bit lower than what you're going to see for, quite honestly, the normal temperature or even the heat index. I think it's important to know that heat index typically is taken in a shaded environment. I think it's also important to know that the location that our athletes are going to be participating in is where we need to take the wet bulb globe temperature from. So if they're going to be on the practice field, the wet bulb globe temperature does not need to be taken in the shade, not near the practice field. It needs to be at the exact environment they're going to be participating in. So what this wet bulb globe temperature allows us to do is it allows us to develop regionally specific work to rest ratios. Now, the American College of Sports Medicine does have guidelines with recommendations for the type, duration, and frequency of activity, for the frequency of hydration and rest breaks, and for any activity modification or event cancellations. The negative to that is this guideline does not take into account any regional variations in environmental conditions. So I think you can see the problem here is for those who typically perform their task or perform their sport in the northern part of the state, or excuse me, in the northern part of the country, their acclimatization is going to be different for those who participate in the southern part of the country. So we published this in 2015 as well in the American Journal of Sports Medicine. What we did was we looked at the American College of Sports Medicine's work to rest ratios, and then we compared it to those that were based in the state of Georgia. And the folks in the High School Athletic Association in the state of Georgia have really done a great job of developing these. So what you notice is that a wet bulb globe temperature of greater than 90 degrees, if we did that in our southeast part of the state, southeast part of the country, we really would never allow our athletes to participate. So our athletes are a bit more acclimatized to a higher wet bulb globe temperature, but it's still important that we have work to rest ratios based on different regions. Number 4, it's important that we educate our athletes to match their fluid intake with their sweat and urine losses. So very simplistically, I think of 3 things is we want to drink to thirst. So we want them, when they're thirsty, they have access to fluids. We want them to drink to urine color. And what I mean by this is we want to keep their urine color just a clear to light yellow. And then we also want to drink to weight. So if we've got the resources in place that allow us to weigh our athletes before practice and after practice, and we've got an idea of what their, where they should be at a good ideal body weight, we want to try to keep it as close to that as we can, because what we notice is that over the course of a few days, as we continue to lose fluids, the risk of exertional heat illness and exertional heat stroke can certainly increase. One of the ways we sell this to our athletes and also to our coaches is that we want to make sure that they've got access to fluids, because if they've got more than a 2% loss of body weight, this is going to significantly affect their performance. So almost every athlete that we come across, and certainly every coach that we come across, we want these athletes participating at their highest ability. And one of the ways they can do that is to make sure that they're, they stay appropriately hydrated so it doesn't affect their performance. When we get greater than a 3% loss of our body weight, this really is going to increase our risk of exertional illnesses. Number 6, when we present on this, you typically get a few crazy looks, but I think it's important that if we can avoid the hottest part of the day, we're going to try to do that. Now, I'm not naive enough to think that everyone's going to be able to practice, 6 a.m. to 9 p.m. or 9 a.m. or 6 p.m. to 9 p.m. But if we have the option to go a bit earlier or a bit later, we certainly want to do that. We want to encourage hydration with rest breaks in the shade, and certainly light colored clothing that's going to allow for cooling would be encouraged if at all possible. I think it's very important that we understand what are the risk factors for exertional heat illness, or heat illness in particular. So number 1, medications, right? So our athletes are going to be exposed, and they're going to be certainly have the potential to be under the influence of alcohol or caffeine. ADHD medications we know have the ability to increase our risk of heat illness. If the patient has a current febrile illness, so if their temperature is greater than 100.4, they really don't need to be practicing or participating that day if at all possible. Obese individuals have a more difficult time of dissipating heat that's generated, and they also generate more heat. We talked about excessive clothing or equipment earlier, lack of acclimatization, and then certainly a high environmental temperature or a high relative humidity. And lastly, this kind of ties everything in together, but a well-developed and a well-rehearsed exertional heat illness emergency action plan. And Dr. Nye can really go into this probably way deeper than I can. Is our military personnel, they really go through a very well-developed, very well-rehearsed emergency action plan for almost everything. Dr. Fran O'Connor and Dr. Nye, I've heard them lecture on this extensively, and they do an amazing job. But this is really what's going to hopefully keep us out of trouble. So we want to make sure that we've got an appropriate supply of fluids. We want to make sure that we've got easily accessible ice for cooling of fluids, and then for treatment of these athletes should we have an exertional heat illness or exertional heat stroke. We need a rectal thermometer available and easily accessible to measure core body temperature. We want to make sure that we've got means to communicate with our EMS colleagues. We want our EMS colleagues on board as quickly as possible, but it's vitally, vitally important to know that the treatment of exertional heat stroke, which we'll talk about in just a few minutes, the mantra in our exertional heat stroke world is we want to cool first. So we want to cool on site, and we want to transport second. This typically occurs, this typically takes about 15 to 20 minutes. But if we've got that rectal thermometer there, we know we want to cool these patients to a core body temperature of somewhere around 101.5 to 102 degrees Fahrenheit. If we do not have access to a cold water immersion tub, Tarp-Assisted cooling with oscillation, which we'll talk about in a few minutes, is the only other preferred method that allows us to decrease these patients' core body temp at a rate that's appropriate, that's going to decrease their morbidity and decrease their mortality. All right, so when we discuss the appropriate management of exertional heat stroke, I think it's important to break this into two buckets. So we've got the pre-hospital management, or the pre-hospital care of exertional heat stroke, and that is the number one most important thing. There are very few things. I don't think it's inappropriate to say there are zero things that we can do in the hospital that will alter the morbidity, that will alter the mortality. It may alter the morbidity somewhat. If we have not cooled these folks appropriately on scene or on the site of collapse. So when we look at the management, we've got the pre-hospital care, and then we've got the hospital care. And it's important to say that the hospital care really is going to build on the pre-hospital care that these patients receive. So what does the pre-hospital management of exertional heat stroke look like? It looks like a big tub of ice with a bunch of water. And that's a very simple treatment, but we have to have access to it. That provides the most rapid way to lower the core body temperature at a rate that's appropriate. This needs to occur within the first 15 to 30 minutes of collapse. And if this happens, we've got study after study demonstrating a association with 0% mortality and very limited morbidity. Unfortunately, there are situations where this does not occur, and this is typically secondary to a lack of pre-planning or a lack of an emergency action plan. Both the American College of Sports Medicine and the National Athletic Trainers Association strongly recommend on-site treatment or on-site cooling for exertional heat stroke. As I said in the previous slide, the mantra is cool first and transport second. So this is going to get us to a core body temperature of around 101.5 to 102 degrees Fahrenheit. We know that treatment with cold water immersion requires a significant amount of pre-planning for this to occur appropriately. So Dr. Nye and myself had the opportunity to be on the consensus statement for the pre-hospital care of exertional heat stroke a few years ago. So, and the next few slides I'm going to show you are going to be taken directly from this article. So this is I think it's a 4-page article. You can read this in less than 20 minutes. And this will probably tell you everything you need to know about the pre-hospital management, the pre-hospital care of exertional heat stroke. So for those of you who have not read this yet, take 20 minutes after we finish this lecture and go read it. It's wonderful. It's very high yield. It's easy to read, very easy to understand. We had the opportunity to sit around in a conference room with folks from the emergency medicine world, folks from the inpatient world, athletic trainers, sports medicine physicians, et cetera, and really kind of put together what we think is a very practical, easy to understand, high yield publication. So the basic paradigm for the care of exertional heat stroke is rapid recognition, rapid assessment, rapid cooling, and rapid advanced care. So what does rapid recognition look like? Well, first off, it involves all of us. So it involves all of our sports health staff. It involves our coaches. It involves our athletes and our teammates. It involves our first responders. It involves our EMS staff. And our EMS staff is a lot of folks. It's our EMS physician, it's our emergency medicine physicians. It's our EMT paramedics, and there's our dispatch. The picture that you see is a picture of a kid who was 14 years old who passed away about an hour and a half away from where we live here in 2014. We had an opportunity to review the 911 call when this occurred. So he was practicing a 2 or 3 a day practice on the first or second day of camp, which clearly was not appropriate. But he collapsed, and the coaches called 911, and the EMS dispatch recommended that they not cool the athlete too quickly. So this is one of the kind of the thoughts in the dispatch world where patients can be cooled too quickly. And what we know is that patients who are hyperthermic, not normothermic, but hyperthermic, cannot be cooled too quickly. Now, conversely, they can not be cooled too quickly, which leads to catastrophic outcomes. Unfortunately, he succumbed to an exertional heat stroke and passed away almost 10 years ago now. I think that gives us an opportunity to really get proactively involved with our EMS colleagues. They do an amazing job. They save lives. This is one of the few things where loading the patient up in the back of the ambulance and transporting them to the hospital is really not the right answer. So if we've diagnosed exertional heat stroke appropriately with a core body temperature and we cool these athletes on scene, they will have a great long-term outcome. If we make the diagnosis and we put them in the back of an ambulance and we transport them to the hospital, for all intents and purposes, we've lost that 15 to 30 minutes where they need to be aggressively cooled. And this was one of the things that came to light as we were putting this consensus statement together. So for rapid assessment on my differential, when I've got a patient who's physically active and they collapse and they've got central nervous system changes, these are the things that go through my mind. So 1 is exertional heat stroke, 2 is exertional sickling, 3 is a cardiac arrhythmias or cardiac arrest, hyponatremia and hypoglycemia, right? So if we've got a rectal thermometer, we can make this diagnosis pretty quickly, or we can exclude this diagnosis pretty quickly. I think it's important for those of you who are partnering up with your EMS colleagues and your emergency medicine physicians, and I would encourage us to do this on a yearly basis. When we started this years ago, our EMS protocols did not include obtaining a body temperature of any kind. We've been able to get that changed, and that's one of the things that we're proud of, and I would encourage you to do that. This is an algorithm that just essentially takes you through what we just said. So we've got an athlete who collapses. We want to assess their responsiveness. We want to assess their central nervous system function. We want to attain vital signs, including a core body temperature obtained rectally. If it's greater than 104 degrees Fahrenheit, we want to initiate whole body cooling. Once we get their core body temperature down around 102 degrees Fahrenheit, these folks need to be transported to the hospital. So rapid cooling should begin within the first 15 to 30 minutes of collapse. So if we've made the diagnosis, the sooner the better. The goal for cold water immersion really is to get as much body surface area as we can cooled as quickly as we can. If we don't have a Rubbermaid tub, or we don't have a kiddie pool to cool these folks down as quickly as we can, a tarp that you can get at Home Depot or Lowe's or Walmart is appropriate. We just want to make sure that we've got as much body surface area as we can covered in ice. So my story on Tarp-Assisted cooling is 4 years ago, one of our local schools here in town had football going on their practice field, which is where their cold water immersion tub, and they had outdoor off-season conditioning for basketball going on the track. So this was in October. We didn't have a wet bulb globe temperature on the track. It was down by the football field. So I don't know what the number is off the top of my head. But the temperature that day was about 98 degrees in October here in the state of Florida. We had one of our basketball players collapse on the track and just started acting very erratic. And fortunately, we got 2 athletic trainers there that did an amazing job. They didn't have a cold water immersion tub on the track because it was not in the same location as the football practice field. But our athletic trainers, all of our athletic trainers carry a tarp in their bag. So we obtained a core body temperature on him, or she did an amazing job. His core body temperature was 108 degrees Fahrenheit. He was cooled on site with a tarp and ice and water. He was transported about 25 minutes later to the hospital, and he walked out of the hospital the next day, and I saw him in clinic a week later, and he was doing fine, did great. So, a tarp-assisted cooling is going to be our backup method for rapid cooling. And this is what it looks like. So the picture of the cold water immersion tub is just a 150-gallon Rubbermaid tub. This was taken from Doug Costa and his crew at the Corey Stringer Institute. This image was. And then the other one is what a tarp-assisted cooling looks like. And this is taken from Polar. So you can order these commercially from places like Polar. You also can just use a tarp, a tarpaulin that you can get from Home Depot or Lowe's or Walmart, et cetera. So transportation should occur after the patient has been cooled appropriately on site. All right. So if on-site cooling is unavailable, and I hope in our situation this never occurs, but if it does, we want to cool these patients as aggressively as possible during transport. This is typically going to include cold, wet towels, cold IV fluids, but I think it's very, very important that you understand is these two techniques will not get these patients cooled quickly enough to guarantee decreased morbidity and decreased mortality. This was published by Dr. Acosta and his crew in 2005, and this looks at the cooling rate. So essentially what you need a cooling rate of about 0.15 degrees Celsius or per minute, or 0.27 degrees Fahrenheit per minute to guarantee no mortality, and decreased morbidity. And what you notice is that the two things that give you this are Tarp-Assisted cooling and cold water immersion. Now, one thing that I think it's important to realize is that the cooling of these patients typically occurs more rapidly on the back end than the front end. So if you are watching someone that's got that you're obtaining their core body temperature continuously, so they've got a thermistor in place, and they're cooling them, and you notice that they don't change it a lot the first few minutes, don't get discouraged about this. This will rapidly cool on the back end as opposed to more on the front end. For comparison's sake, cold IV fluids cool at a rate of about 0.06 degrees Celsius per minute, which clearly does not reach the rate of cooling that is necessary to guarantee outcomes in these patients. So rapid advanced care, few hospitals really have a mechanism in place for rapid cooling of patients. It is important that we communicate the need for rapid cooling as we're transporting someone. When we had the opportunity to put this consensus statement together, one of our emergency medicine doctors suggested that the decontamination room is a really good viable space for emergency departments to use for rapid cooling in the event that we know that we're going to host a large scale road race, or we know there's going to be a heat wave potentially in the next few days. So these are just things to think about for those of us, or those of you who work in the emergency department. So to summarize, rapid recognition, rapid assessment, rapid cooling, and rapid advanced care. So what does the hospital management of exertional heat stroke look like? So this is really just continuing what we hopefully have already done in the field. Okay, so we can begin cooling with the most aggressive method available, but the reality is it's likely going to take more than 30 minutes to get that patient from the time of collapse through the emergency department or into the emergency department to start cooling. We want to assess their ABCs. We know that the late stages of exertional heat stroke resemble those of systemic inflammatory response syndrome, and the protocols for the management are very similar. But if we've lost that first 30 minutes, the chances that these patients are going to have a good long-term outcome is very, very low. Laboratory evaluation, most certainly going to see renal injury, so hepatotoxicity, electrolyte abnormalities. Radiographs and EKGs is necessary. Certainly we want to consult our medical colleagues as necessary. In regards to medication management, there has been some discussion about dantrolene as a possible medication management. This is certainly used in malignant hyperthermia, but the data really has not backed this up as a treatment for exertional heat stroke. And then certainly we should expect inpatient admission for these patients. The long-term complications really are going to be determined by how quickly this is diagnosed and how quickly this is treated in the field. So timely recognition, timely treatment at the site of collapse, at the time of diagnosis, really determines what the patient's outcome is going to be. I'll reiterate it one more time. No inpatient treatment is going to replace the morbidity and mortality benefits in these patients who are aggressively cooled at the time of diagnosis. So our last goal and objective, what does the return to play look like after an exertional heat stroke? Dr. Asplin and Dr. O'Connor published a very good return to play criteria in 2016, and then Dr. Lopez and her partners down at University of South Florida published one for high school football players in the Journal of Athletic in 2018. And these both are saying essentially the same thing. I think it's important to note that we don't have definitive evidence-based return to play guidelines currently, but that's certainly something that is being worked on. The general consensus is pretty straightforward, is we want to gradually progress these athletes to activity once their symptoms have resolved, once their laboratory and diagnostic testing normalizes. If they cannot progress back over the course of about 4 to 6 weeks, it is not inappropriate at all to consider formal heat tolerance testing. And this is typically done in a lab. Dr. Casa and his crew up at Corey Stringer Institute. There's a few other ones across the country that do this. Nate can correct me if I'm wrong here, but I know that Dr. O'Connor and actually Dr. Nye may be doing this as well with our military personnel. So this is what it looks like, certainly for the first week. We're not even going to consider exercise, and I would say even for the first week or two. After the first week, we want to have medical follow-up. Once these athletes have been cleared to return to activity, this typically occurs over the course of a couple of weeks. We're going to gradually increase their activities in a cooler environment, and then we can add heat and humidity as they tolerated. If they have difficulty getting back to activities at the 4-week mark, this would be the time where we would consider potentially initiating formal heat tolerance testing. And this was published by Dr. Lopez and her team at the University of South Florida in 2018. And this is also saying essentially the same thing. So this is return to play after exertional heat stroke in a high school football athlete. So we want to make sure that their laboratory results normalize. We want to make sure their symptoms have resolved. We want to make sure they get clearance from a physician, and then we gradually progress them as tolerated. Nate, how am I doing on time? I can stop here, but I wanted to advocate for one other thing if I've got a few minutes.
Yeah, you're doing well. Why don't we plan on taking another 10 minutes or so, 10 to 15, and then we can leave some time for Q&A.
Okay, perfect. It's probably not going to take that long, so we should be done in time. So
I'm sure the fellows won't complain.
Perfect. So I'm going to use this slide to brag about the people in the state of Florida, particularly our athletic trainers, our coaches, our administrators, our physicians. But I'm also going to really use this to encourage all of you to advocate for policy change. So in 2017, this article was published in the Orthopedic Journal of Sports Medicine, and it ranked the state of Florida as 23 out of 51, if you include DC as well, in regards to implementing evidence-based best practices for the prevention and management of the leading causes of sudden death and catastrophic injury within our secondary school athletes. So it was about the same time a few of us from the University of Florida, some folks from a group called the FASMED, which is the Florida Alliance for Sports Medicine, met, and we knew that we needed to make some changes. And these changes really centered around access to AEDs, access to cold water immersion tubs, access to athletic trainers. And over the course of a 5-year period, we were able to go from number 23, and this was published not published, but was just released in 2022 to number 1. So what does that look like? What do we do? So unfortunately, it took a death of another kid in our state in 2018, a kid by the name of Zachary Martin down in Southwest Florida. And his mom became just an amazing advocate for awareness of exertional heat illness in our state. So in June of 2020, our governor passed the Zachary Martin Act for the state of Florida. So what does this do and what does this mean? Well, essentially what it does is it makes training and resources available to all member schools for the effective monitoring of heat stress. It requires that these member schools monitor heat stress and modify their athletic activities based on these work to rest ratios or these heat stress guidelines. It makes cooling zones available. So we've got to have an area where these folks can cool themselves and get cooled. It established hydration and electrolyte guidelines. It made each school's emergency action plan include a process for on-site cooling, whether that uses either cold water immersion or Tarp-Assisted cooling. And then each athletic coach and sponsor of extracurricular activities that were involved in any outdoor activities at all have to complete annually a training in exertional heat illness identification, prevention, and response. So Nate, I think that's all I have. I wanted to try to stay on task as best I could from a time standpoint. This is my youngest daughter and myself back in the Panhandle beaches where we all grew up playing around on a paddleboard. So I love that picture. It's to me is the most beautiful beaches in the world. If you ever get the opportunity to go, you should certainly explore it. That was taken from an iPhone with no adjustments to the water at all. So I love the color of that picture. So I'll take any questions that anyone has or any conversations or critiques or thoughts, etc. So.
That's awesome. Yeah, no critiques. That was awesome. Thank you so much for sharing all that. I think the fellows are being a little bit bashful or else multitasking right now. So I have some questions for you that I think, well, one question did come in and he was asking, do you do the rectal thermometer, the rectal temperature on site or in the hospital? And I answered that for him. Actually, you answered it for him after he asked the question. But I would re-ask it, what if you don't have, and I'm just going to postulate for the fellows who may be sitting there thinking, well, what if I'm on the sideline and I don't have a rectal thermometer. The athletic trainer doesn't have a rectal thermometer. What do you do?
Yeah, that's a great question. There's a slide that I can send out. So my thought process, I typically go through what's going to kill this person in the next minute, what's going to kill them in the next 10 minutes, what's going to kill them in the next 30 minutes to an hour. So the first thing I would do is hope I had an AED, and I would put an AED on them and see if it suggests that we administer a shock. And if it doesn't, then at that point in time, and I've gone through my ABCs, and let's assume they've got a pulse, that I've ruled out a cardiac etiology. The next thing in my mind that's going to, I'm assuming we've worked through our ABCs here, and we've got a pulse, and we've ruled out a cervical spine injury, and we're not worried about a pneumothorax or something like that. And in my mind, I think this is an exertional heat stroke, but I don't have any way to diagnose that. I would go ahead and start cooling them. Certainly if they're at practice or they're at a game and it's hot and it's humid and that has entered my differential. I don't know of any negative consequences for patients who we know are hyperthermic and are cooled. Now, the question kind of becomes, how long do you cool them for? The suggestion, I think it was published in the Journal of Athletic Training in 2015, but the suggestion is 15 to 20 minutes or until the patient starts shivering. Ideally, we would have a way to measure that, right? I mean, it's going to be really hard to not transport that patient. You should always transport that patient if EMS is there, if you don't have a core body temperature obtained. But if you do, and you made the diagnosis appropriately, I think you have every right in the world to cool them appropriately on site.
Yeah, I wouldn't have said anything different. I think I would have done the exact same thing. Just cool, because you're not going to hurt them by cooling them.
You're not. I completely agree.
Another good question just rolled in from Jill, and she was asking, do you take the pads and helmet off first, or do you just go ahead and get them in the water?
Well, time to cooling is more important than taking off the helmet and the pads. Now, if you've got a way to take it off, if you've made the diagnosis in the first few minutes, and you can take the helmet and the pads off, within a minute or two, I think that's okay. But I wouldn't let taking off the helmet and the pads prevent me from cooling them. I would not let that delay. I would not let that delay me from cooling them. That's also a fair amount of data on that, published by the folks out at, I think it's Central Michigan University. So those guys have done a great job there of looking at cooling rates with the pads and the helmet on. And those people have good outcomes. So if you can get the helmet and the pads off quickly and you can cool them quickly, great. That's totally reasonable. But do not let that prevent you from cooling them in that first 15 to 30 minutes.
Perfect. Got another question coming in. So thanks, fellas, for not being shy. I know you got good questions. So I've got more to fire at them too, but I like to hear your
fire away.
Yeah. So do you need to circulate the water, or do you just let them sit there in the water, or does it need to circulate, and why?
Yeah. So the term, right, is so if we're looking at the TARP, it's Tarp-Assisted cooling with oscillation. But yeah, it's certainly circulating the water is recommended if at all possible. Yet again, we need to understand what our resources are, right? So if we're the only person there, or there's one athletic trainer there, we want to get them in the water. We want to get them in cold water first. If we've got extra hands that can help us, we've got to think about how we're going to make sure that these patients stay upright. So an easy way to do that would be to put a towel or a sheet underneath their underneath their axilla, and that way you can hold them up. I think can go back to what we notice is that this patient here, there's two people there, so we're just making sure that the patient doesn't fall down in the water. Yet again, I don't think the concern of drowning should I mean, certainly that should be on our radar, but these folks, there are ways we can keep them, keep their head out of the water. But yes, if we can oscillate the water or move the water around, that's absolutely recommended.
Yeah, for sure. Keeps the cold water in contact with the skin, just carries more heat away from the patient and stuff. So Good stuff, guys. So Peter Zhang asking, any data on the correlation between a temperature check on the forehead versus a rectal thermometer? And
Yeah,
yeah, go ahead.
you want to take that one, or you want me to take it?
Sure, I'll take a stab at it. So the body has a temperature gradient when you're at rest, and it gets even bigger when you're exercising. So your body's sweating and you're dumping heat from your skin. So your body's going to be the hottest in your core, and it's going to be the coolest on your skin. So any type of temperature that's checking the temperature at your surface, whether it's in your mouth, now especially if you're drinking cold water, your mouth is going to be cold. Cooler than your core, and any part of your surface, whether it's your forehead, your ear, anything other than a core temperature. Now there's two ways, well, really three. You can get a endovascular, if you can, like in ICU, you can check a core temperature through like a central line. Clearly can't do that in the field. In the field, you could theoretically do an esophageal temperature, but you're going to make them gag and throw up, and it's really unpleasant. So the best and most feasible route to get a core temperature in the field is rectal. And that's the only temperature you should do. In fact, you should avoid, not just ignore the surface temperature, you should avoid checking a surface temperature, an oral, an auricular, because that can give you a false sense of security that their temperature is normal, and delay their care if they actually do have a heat stroke. Anything to add to that, Seth?
Yeah, there's I mean, just do a PubMed search. There's numerous articles comparing validity of essentially exactly what you said, validity of core body temperature obtained rectally in the field. Certainly in the ICU setting or the inpatient setting, there are more invasive ways to monitor that. I think it's important for the fellows to know. I'll piggyback a little bit on what you said, Nate. You may have seen like some of the college football programs or certainly the athletic programs with a bit more resources. There are some ingestible thermometers. So these little pills that give a reading. And those are typically used for folks who are more susceptible to exertional heat illness or who have had an exertional heat stroke in the past, where there's an external monitor, a handheld monitor that you can get a fairly good idea of what their core body temperature is. But yet again, that's resource intensive and somewhat invasive, and gives a comparable temp to a core body temperature that you would obtain rectally with a thermometer or a thermistor.
Yeah, perfect. Yeah, we sometimes use those with our special operators who are out in the field. Remote areas. You can watch their GPS location on there too with it. Cool. So now with a heat stroke, we see altered mental status, and whether they're combative or whether they're just completely confused, or maybe it's subtle. But do you expect to see their mentation improve once their temperature comes down?
I mean, I certainly think you expect it to improve. I think it's important to note, once we get their core body temperature down to that, that 101.5 to 102 level, I would recommend that we transport all these folks just for further monitoring to the hospital. And that should continue to slowly improve. I think the important part really is if we've got a way to measure their core body temperature, we want to make sure that we've got a starting point. We know that we know what our end point is, and it's very important to know that they may not, if you're continuously monitoring their core body temperature, you may not see a huge change in the first minute or 5 minutes or even 10 minutes or so, but the slope really decreases significantly in the last 10 to 15 minutes of cooling.
Yeah, great point. Yeah, and I would echo that. I think that's spot on. Their temperature is going to drop fast towards the tail end of those 15-20 minutes ish that they're often in the water. And the patients that I've seen that I've cooled, their mental status will remain altered most of the time while they're in the water. They're not going to be happy with it. Being freezing, in freezing cold water, they may continue to be combative. You just need to continue to restrain them if that's what's required, and keep them in the water until they get cooled down, and then they will calm down and they will come to at some point after, usually not that long after they get cooled. So, and I think that's a good segue into the next couple of questions, which relate to medical legal concerns. So the first one here is there any history of medical legal concerns surrounding a provider's desire to keep an athlete at the scene to continue cooling versus an uninformed emergency staff that wants to transport the patient ASAP? How would you handle a situation where EMS wants to yank them, but you are the doctor on site, you want to keep them?
Yeah, I think you should expect that that's probably going to happen. In most of the situations that we've had local or here, it's not uncommon to have a bit of friction at the site. This kind of goes back to one of my slides where I said that this gives us a great opportunity to partner with our EMS colleagues, because for the vast majority of things that they treat, the answer is to get them to the hospital as quickly as they can. They're graded on this. This is ingrained in what they do, and they save lives. This is one of the few things that transporting them as quickly as possible to the hospital is not the right answer. I would almost counter argue that question and say the medical legal is going to be on your side if you have a core body temperature and you treat them on site. If you have a core body temperature and you start cooling them and then you allow them to leave and they're not cooled appropriately, the medical legal will be against you. And it's a very easy, I mean, from a medical legal standpoint, you essentially have nothing to stand on.
Yeah, so true. And I think, so I've never been in that situation personally, but I have certainly talked with a lot of EMS crews and medical directors about, making sure our protocols are in sync. And yeah, there is that concern. Some EMS medical directors, they do want to pull them and get them. So, which is not medically supported, but yeah, you do what's right. You do your best to keep them on site, cooling them. As long as you have immersion or Tarp-assisted cooling available. Now, if you don't have any cooling available, yeah, send them. But if the EMS, the medical technicians, the paramedics are saying we want to pull them and yank them, basically pull them out of your cooling tub before they're cooled, I would demand to speak to the medical director myself, their boss, basically, and I would say, I'd basically have a discussion with the medical director, and I would stand my ground as much as I can. And it's your patient, and in the end, you want to document what you're doing and why, and then yeah, in the end, if there's a bad outcome, you are on the right side if you're doing everything we've talked about here. So good question. We'll transition to one last question. And he's asking about exposure in a public area, patients with their sensitive areas exposed in a public space. Have you ever been concerned about the public, family, or the patient's perception and placing the team in any sort of legal trouble?
That question gets asked every time I present this, and my response to that is, we don't typically think of exposure when someone collapses secondary to a sudden cardiac arrest and we put on an AED, right? I mean, we put an AED on and we don't really think about exposure because we're saving someone's life. Yeah, I think we need to take that into account. I think that's something we need to take into account in everything that we do every day when we see a patient anywhere. But going back to kind of the theme is, we want to be respectful of patients. We want to be respectful of their families. We want to be respectful of exposure at any point in time. But we also have a duty to to diagnose these things appropriately. And that's, as we've said, there's no other way to make this diagnosis in the field except a rectal thermometer. And there are ways to do it appropriately, and there are ways to subtly do it. And there are ways to do it to prevent any concern for that.
Yeah, a couple of tricks that I've seen is if you got a soccer team or a team, you can have the players surround the athlete and kind of face away, form a wall. You can hold up
the use of towels or sheets can be held up.
Yeah, exactly. Or whatever you have, just provide some kind of shield to the visibility. And yeah, good stuff. Well, guys, those are great questions. And
yeah, great questions.
Very thoughtful. And yeah, so get out there. You guys are the experts. When you graduate from fellowship, you are going to be looked at and as the subject matter expert. So this is an area you need to be, take ownership of. I know this is probably something that you're just starting to dive into, but start to own it and live it out there on the sidelines. Any final comments, Seth?
No, I thanks everyone for attending. Thanks for spending an hour with us tonight. Advocate for policy changes, advocate for athletic trainers, advocate for, changes at the state level for your athletes, and our EMS colleagues do an amazing job. This is something that, man, we've got some areas that we can work on communication, but that's kind of why we got into this, right? Is to save lives and to help patients. And our EMS partners are awesome. They do an amazing job. Keep building those bridges, and that way, whenever one of our athletes or patients goes down, we're all on the same team. We're all working together, and we save these folks' lives. That's what we're here for. So,
yeah, absolutely, that's so true. Well, thanks everyone again for dialing in. Appreciate your time, and thank you, Seth, for sharing your time and your expertise with us and your passion for this important topic. I would say I know I am happy to answer, and I'm sure Seth is the same way. I'm going to put my email in the chat. If you have any further questions, feel free to reach out, and we're here to help. A lot of times you just need someone else to weigh in or whatever. So have a good rest of the evening, and we'll see you next week.
Thanks, everyone. Have a great evening.